Good afternoon, everyone, and welcome from QI Talk Time in Dr. Stephen's Hospital. We have a packed room here today. Today's topic is on frailty and understanding the black box of people living with frailty, what really matters to them. So today we have Dr. Philip Crowley with us, who's going to introduce our panel of speakers, and he is the National Lead for the Quality Improvement Team in the HSC. Philip.
Thank you, Roisin. Great to be here, and fantastic group of people here to talk to us today. Starting with Alison Enright, who's a long-term occupational therapy manager in Beaumont for the past 16 years. Ciara O'Reilly, who's a physiotherapist, clinical specialist in physiotherapy, also in Beaumont. And Siobhan Julian, who's a dietitian in Wexford. And I mean, it's great for us as a QI team to host this because it's a really, really important topic. We've very good link with both Beaumont and Wexford General Hospital, and I really look forward to hearing about the kind of innovation that these leaders have been leading in the area of caring better for people who are frail, because we're all moving in that direction. And it's just so much an issue, I think, of our times that I think what's great is that, from my understanding of the work that's been going on, is that in Ireland, as often is the case, we have best practice. Even global best practice, and if we could implement what's best practice in one place in Ireland across the country, we'd have the best health service in the world. So while it's good as an island to look outside, it's really good for us to learn from each other as well, and I really look forward to today's session.
Thank you, Dr. Crowley. 1 second. So I'm Roisin here again. I'm just going to give a quick bit of housekeeping. So today we want to keep it as interactive as possible. So you'll see at the top right-hand corner of the screen a chat box function where you can type any questions or comments or queries in as we go along. So we might deal with them as we go along, or we might leave some time at the end as well for some questions. So please keep that going. You'll see the telephone number and the event number there. You can listen over the computer, but also you can phone in, and the sound quality is generally better if you phone in. We are very active on Twitter, so please get your photos going, take a photo of your team, tweet at QI Talk Time, get some of the conversation going around frailty, and retweet through at QI Talk Time. So without further ado, I'm going to hand over to Alison Enright, who is actually now in the role of Health and Social Care Professional Development Manager here in the HSC in the Health and Social Care Professionals Office, to start our discussion. Thanks a million.
Thank you, Dr. Crowley and Roisin. Thank you for the opportunity to share our reflections on older persons care. I guess it's an area that's a keen interest amongst health and social care professionals, but also our colleagues in medicine and nursing, with whom we're working very closely to improve services. Making our health care systems fit for our aging population, delivering on our salon to care priorities is complex. It involves whole system reform underpinned by co-design. I guess it's important to say that for the purposes of this webinar series, these two sessions, we're going to focus on aspects of the care journey, specifically around frailty, considering what our patients or our citizens want from us and what the health and social care professions can offer. Today, we're going to explore the black box of patients living with frailty, and we're going to discuss the benefits of early assessment. We're going to hear from Ciara O'Reilly in relation to the Beaumont Fit Service, and Siobhan Julian on the work that Wexford General is doing around early assessment. Two very different stages along this improvement journey, and yet both having fantastic results and addressing similar types of challenges. Next time, on the 19th of March, we're going to focus on out-of-hospital care as well. Just to put into context, the health and social care professions comprise 26 different disciplines covering the therapy, the social care and diagnostic domains. And I guess our strength is our diversity as a group, a huge group, a family, but also all that unites us, our commitment to person-centered care, to driving and leading change, to research and innovation, to integration, to being able to make a difference on the fringes between acute and community care, where we work really well across boundaries. Our focus on the outcome, but measured from the patient perspective, our appetite for quality improvement in all that we do, and our ability to move into extended scope of practice, moving to the top of our license to realise best impact and value, and of course our focus and skill in terms of information and technology. This workforce is the second largest clinical workforce group, so we have collectively 16,000 people within this family. We're accounting for 20% of the pay budget, 25% of the clinical workforce, effectively at a minimum 25% of the solution in terms of the challenges we face in unscheduled care. In 2017, the National Health and Social Care Professionals Office was launched with the specific aim of strategically leading and supporting the health and social care professionals to maximise their potential and achieve greatest impact for all things person-centred integrated care, so all stages, design, planning, management and delivery. A key focus of the National Office at the moment is on supporting and enabling the health and social care professionals to realise their impact, their best impact, and crucially to provide solutions to the challenges we're all facing, and particularly our patients and their families in terms of how unscheduled care services are delivered. Our model's not working. Capacity is something that we view as beds, but we're not viewing it in the way it needs to be viewed, as the right place, right time, right intervention for everyone, every time. We know that harm is caused by hospitalisation. We know about deconditioning. We know about the risks of it, and so early on in the patient journey of hospitalisation. We know the system doesn't enable choice. Most of our patients tell us they want to be cared for at home, and yet we don't have this option available to them. We're spending money often in places where we're not achieving good outcomes for patients. Money is being spent on transitional care beds, although we know that the evidence tells us the conversion rate to long-term care for patients who attend transitional care beds without rehab is far higher. It's 80% higher indeed. So we know that money could be recycled and used differently to support new models of care that would focus on rehab, reablement, bringing our patients home, bringing healthcare home to where they want to be. Adding to this is our ageing demographic, the fact that also we know that a small number of our patients are using a lot of bed days, so 12.5% of discharges use 57% of bed days. It's not surprising because now we know that we're dealing with complex comorbidities. That is the place we're in our healthcare service now. Tilda's findings are an absolute wake-up call for us. 45% of community dwelling over 65-year-olds are pre-frail, and pre-frail symptoms are reversible, they're preventable. We know from our fantastic Tilda data that actually we need to build and design models that support engagement, that support meaningful relationships, because we know these actually reverse pre-frail symptoms. And really worryingly, we know that 24% of our current over 65 population are frail. It's simply incumbent on every one of us to reorientate our services to meet patient needs.
Now, we're going to try something a little bit new with QI Talk Time today. We're going to try and share a video with you, so just bear with us while we do that.
To lead into the video, one of the patients who falls into that category of being in the 12.5% who use 57% of bed days was Patrick. And this is Patrick's story.
This is Patrick's story. Patrick is 82 years old and lives with his wife. On Wednesday night, Patrick had a fall at home. He was brought by ambulance to the emergency department. The time was 2:15 a.m. Patrick had been discharged following neurological surgery 3 weeks earlier. He had a history of cognitive impairment, He was mobile with a walking stick, he needed minimal assistance with dressing, and he was confident. Investigations were ordered, including lab tests, a CT brain scan, telemetry, and lying and standing blood pressure. These showed no significant abnormality. Patrick wasn't assessed for frailty in the emergency department. Still, Patrick was admitted to hospital after 17 hours. By day 7, no comprehensive geriatric assessment had been carried out. Patrick hadn't received any rehabilitation, placing him at great risk of deconditioning, and the level of stress his carer was feeling had also not been uncovered. On day 8 of his admission, Patrick was assessed by the occupational therapist, physiotherapist, dietitian, and geriatrician. On the ward, Patrick was mobile with a walking stick, independent with transfers and self-care. He scored 25 out of 29 on the mini mental state examination. A plan for discharge home was documented in Patrick's chart. However, it was noted that his family expected him to be transferred to nursing home care. By day 11, Patrick wanted to know why he was still in hospital. His risk of deconditioning wasn't addressed. No flow tools, such as the safer bundle or rent-a-green days, were used on the ward to avoid delays in Patrick's inpatient journey. By day 14, Patrick's medical chart noted that he was awaiting transfer to nursing home care. Patrick's family wanted him to go to a nursing home, but Patrick didn't want to go. No one asked Patrick what matters to you. No one advocated for Patrick's wishes. By day 21, Patrick was wandering on the ward. An old-age psychiatry review was requested on day 25. At 30 days, Patrick was found on the floor after a fall. He was mobile with a Zimmer frame, needed supervision for transfers and dressing, and was incontinent and using an incontinence pad. 39 days after admission, Patrick was discharged to a nursing home. Patrick died 1 year later in the nursing home.
Okay, hope you all got to see that okay. I'm just going to hand back to Alison while we get the slides back up again.
Well, imagine being taken from your home, never to return again. This practice surely should be eliminated. Assessments and decisions about longer-term care should never be taken outside the person's home. Our thanks to Dr. Emer Ahern and her team in St. Luke's General Hospital, who shared this story with us. Patrick was one of their patients, and indeed Patrick's story was a catalyst for the excellent improvement work that they have been progressing over the last couple of years.
Alison, just before we move on, a question has come in there from Rachel Armstrong asking what measures were used to score the over 65 as frail or pre-frail. We might hand over to Kira. Do you want to pick that up?
I suppose that's from the TILDA study. I'm not sure what they do. I know they look at they use times up and go, some measures, and they also look at, they look at all the different components of frailty, looking at their falls, the polypharmacy, and cognition. But I'm not actually sure what exact data they use, measures they use to score the frail and the pre-frail.
We can actually embed that link into the TILDA study into our slide set for you, so that will be available online after the QI talk time, Rachel, so hopefully that will help to answer that question.
Thanks, Rachel. The Integrated Older Persons Programme has developed a 10-step integrated care framework, a really sound roadmap, but as we navigate implementation, we need to design and plan really well. Professor John Bolton has designed a model for what a good health system looks like, with the right care in the right place, rehab, reablement services available through a recovery plan, and one that stresses that only 0.8% of our patients should actually require long-term care. Currently, 8 to 10% of our patients are being transferred to long-term care. Smart hospitals focus on the admission pathway. They focus on early assessment and short stay and assertively managing frailty and tackling deconditioning. The UK's Acute Frailty Network sets out 10 principles, the first of which, again, is to establish a mechanism for early identification of people with frailty, a key starting point, surely, for all Model 3 and 4 hospitals. And we know it works. Some data from, again, St. Luke's Hospital, following intensive improvement work, where they focused on the acute floor and early assessment, identification of frailty. They found a reduction in 7-day readmission of 29.4%. Interestingly, St. Luke's have made a fantastic observation that the reduction in long-term care conversion rate between 2017 and 2018 has dropped from 26% to 5%, really quite staggering. And that is as a result of a system change where at the beginning of that is the identification of frailty, and then through the house the work has been done to improve systems in terms of flow and pulling patients. What we are learning, I'm going to leave this slide because I know Kieran intends to share a little bit about this in her results in a moment. So I'll move straight into what we're learning from our patient stories, and it's alarming. We're learning that our patients are afraid to come to ED. They leave it until they're in crisis. They feel the only way to access acute services is to be admitted. Everything we know we shouldn't be delivering in terms of care. We know that prevention services are not there. This is really concerning. We're seeing patients who are immobile, they're in pain, they're malnourished, they have undiagnosed cognitive impairment, they have incontinence issues. We are meeting families who are absolutely unable to cope at the end of their tether. We see that it's easier to admit patients than discharge patients because of the complexity of care, because people don't fit single pathways. We know that we don't have intensive rapid response services, and we know that's what's needed. We've got a recent test around that, and we know that short-term intensive intervention, 2 to 4 weeks of rehab and reablement, is what is needed. It's a gap. And we know that we don't have alternative care pathways in the UK. There are terrific results from paramedics working with therapists to avoid presentation in the emergency department. But we're delighted to say that a test between the National Ambulance Service and Beaumont OT and the wider Beaumont team is about to commence. So we're really eagerly awaiting those results. So far, there are about 15 front-door early assessment HCP services in Model 3 and 4 hospitals. Some of these are developing, often without resourcing, but responding to local needs. This reorientation of services is really encouraging, and it's a signal of the readiness in the system. But as with any seed of change, first it is necessary for us to understand the environment, to characterize it, to measure the elements of soil, to conceptualize it. And that is just the beginning. The time is right now, we feel. For us to optimize older persons' care, we really need to standardize the way in which we're working. We need standard work practices around early assessment, and we need standard competencies in terms of workforce to deliver this care. We need to agree data sets that can be integrated locally into local governance, in order for them to be metrics that matter, metrics for improvement, not metrics for accountability. And we need to be able to share widely our learning and experiences. And we really can take a lot from the Ireland East Hospital Group and their service improvement team, who's making huge inroads in terms of sharing and helping our understanding and best practice in terms of managing frailty. The National Office at the moment is in negotiation with the Quality Improvement Division to plan a co-design approach to building a national network of frailty assessment teams and designing together what standard practices should look like. And just finally, before I hand over to Ciara, I really do think it's worth emphasising that the workforce is the answer to capacity. We have a huge opportunity with our greatest asset. So if we're serious about good care for everyone, we need to challenge ourselves to balance specialisation and generalisation. Right care at the right place at the right time. Often we've too many disciplines doing the same work. This analogy is intended to show that through the white of the egg. There's a lot of duplication, which we need to eliminate because it is waste in the system. We cannot continue as we are because we simply can't meet demand and ever-increasing demand. Instead, though, we have huge opportunity to foster cross-competency working, and we're seeing great examples of innovation of this, and Kira will elaborate on that. That's really relevant where the work is not unique in terms of our individual specialty contributions, so there's plenty of scope for cross-discipline working. In addition, we need to look at skill mix. It needs huge attention. In order to truly embrace risk and enable choice, we need senior health and social care professional decision-making. We need advanced practice roles. We need clinical specialists who can clinically lead teams. And that makes it much safer to embrace what we know is going to enable re-ablement, and that is the development of assistant positions and assistant service-led services under the supervision of senior staff. We need a workforce that is flexible. If we're to truly follow patients and their complex needs, we need staff who can in-reach and outreach. We need staff who have had the experience across the continuum of care, the acute, community, integrated care, end of life. We need to create opportunities for readiness to enable in-reaching and outreaching as we work to develop shared governance models. And we need to ensure that our training, our undergraduate, our postgraduate training, is aligned to service requirements. And finally, it's really important that we are resourced for demand. There is a certain amount that can be done and is being tested in terms of reorientating existing staff. That's very difficult in, for example, Model 3 hospitals where their workforce complements are really so small. It's very difficult for them to reorientate far. There is a need to think about innovative ways of recycling money as a solution to investing in new ways of embracing capacity in our teams. And we also need to invest in HSCP leadership. We have less than 10 health and social care professional executive leads nationally. I often say this to my nursing colleagues and they find it unfathomable, and quite rightly, less than 10 in the country. This kind of scale of change and pace of change requires and deserves for our patients and our system an investment in leadership structures, and we're working to design and understand what they should comprise. So I'm going to hand over to Kira, who is going to talk us through her work in the Frailty Intervention Therapy team in Beaumont Hospital.
With Alison. So I'm going to start kind of talking a bit. So let's talk a little bit about my life before FIT. I suppose I've been a physio and working in Beaumont, and I was in one of those lovely little boxes, and I was working in these rehab units, and I would have been very focused on the physio side of things, their mobility, their transfers, their balance, and on what could the patient improve in all those scores. Because what I didn't challenge myself to think about was how that translated from a patient-centered care point of view to their requirements from their ADLs. Their balance was intact, their Berg score had gone up, but could they dress themselves now? If I'm doing a stairs assessment, great, they can go up and down once, but if their toilet is upstairs, do they have the endurance to go up and down multiple times a day? Do I need to consider downstairs living? Do I need to contact a public health nurse to get a commode? These are things I hold my hand up I didn't think about prior to FIT. We were siloed working, and I suppose the biggest change in my practice has been that bigger picture piece, thinking about what my patients need across their life to get home. It wasn't necessarily about physio, it's about what the patients need. And so I suppose what the hospital system is a bit like the London Underground system for patients to navigate. Very, very challenging. And so we love in the hospital for patients to fit into pathways. But I suppose what we have found with older people is that they don't fit neatly into a pathway. They don't present with a very clear diagnosis that's easy to navigate the system. And that's why we feel very strongly that you need a clinical specialist role, a clinical leadership piece in the emergency department to help guide the right decision-making around these patients. Are they safer to go home than come into the hospital, or vice versa, do they need to come into the hospital to make sure we're putting them on the correct journey, that we can make sure we maintain them at home and longer term, because we know that's what patients want to be. So the FIT team, for those who aren't familiar with the components of the FIT team, it's a multidisciplinary team. We have physio, OT, speech and language therapy, pharmacy, social work and dietetics. When we started this, our team in Beaumont on the 21st of September 2015, drilled into my brain forever. The hardest day of my life. We went down to the emergency department and we worked very closely with the ED medics, ED nursing and the on-take team. What we had was a really strong advocate in one of the emergency physicians who worked really closely with us. She felt very passionately about, she was down there by herself for the last 10 years working, finding the elderly patients, but she didn't have this therapy team around her to support the decision making. I suppose how we, on a daily basis, how does this work? We go in every morning, we go find our patients, which is probably the biggest change in my work. Prior to this, if I had seen a referral from a doctor for ED, it's like, they're in ED, we'll leave them there till they get to the ward, which was totally the wrong way to think, but that's how we thought, and we thought that we were doing the right thing. And where now we go and we find the patients, and we start the process. Sometimes we can see patients in conjunction with the doctors at the same time and the nurses, and we're starting that therapy assessment from the front door, and depending on everything from a functional point of view, from a social, from a swallow, from a language, from a nutrition point of view, and a medication. We're looking at everything at the same time as the medics are doing their investigations. We're not waiting to be asked to see these patients because we know they will have needs. We just have to start, we have to go and take the ownership and find these patients. And I think probably the growth we've seen in the last kind of 6 months with our team has been, we have candidate A&P working with us, which has been, I suppose we never had the specialist nursing piece with us, and I didn't know what they could bring, but it's been phenomenal, the level of expertise that the candidate A&P has been able to bring to our team. We also have allocation from the geriatricians and 0.5 consultant time working with us, which has just been incredible. We felt that I always knew we could get more people home if we had that geriatrician working with us, and on a daily basis we turn around more patients in the ED by having that geriatric consultant, even a registrar level working with us. We would definitely get more patients home than we just did as a therapy team alone. How did we do all this? I suppose that's why we're here in the QI division, because we use the QI methodology. I wasn't really familiar with it before we started this journey, so it was a learning process for us all as we went through it. Looking at doing the rapid tests of change, I think we really found it so beneficial because we didn't do the old model of, oh, we'll try something for a month and see if it works. We tried it for a day, 2 days. If it didn't work, we had that frontline ownership to change it, and we changed it immediately. We didn't wait to see if it worked. We tried it, we measured it. If it didn't work, we just moved on. Even just some small examples where the age profile of patients we started with 80, then we went to 79, then we went to 78. We took our time, but we made sure that we could cope with the changes we're bringing to the system. We changed our lunch hours, we looked at staggered lunch breaks, all these little things. I suppose one of the biggest ones we did was we went to Brighton on a site visit, and we really used that QI one of we stole shamelessly. And we had this beautiful document we thought of 8 pages of all this essential information, and we went to Brighton and they had all of the same information on 1 page. And we were like, what are we doing? So we asked them, could we take it? And they were, of course, there was no problem with it. But we realized we were actually, kind of what Alison was talking about there, we weren't just duplicating, we were actually quadruplicating. I don't even know if that's a real word. But we were writing the same thing so often. And what we found was by changing that work practice, we created more capacity within our team. We estimated by using measurement of time, and we created probably about a whole time equivalent within our own team by just changing the documentation. So by looking at what we were doing, we were able to change it so easily. And our staff, another thing that's come, as we've now developed interdisciplinary competency document for our staff grades working within the team. So that is continuously changing and improving the process as we go along. I think probably the biggest change in in the system that we found is with the home first ethos we have in place now. We know that there's such a difference for getting the patients home. We've seen it. Like when I go back to the wards now and I see that these patients on the wards, I see them become more confused, weaker, and right in front of my eyes. So, and we know when we've brought them home, we do an outreach visit, and we can see that the patients are better at home. They want to be at home. So it's challenging it from the front door, and I suppose what the medics in ED had said to us before we were there, they just didn't know, they couldn't send people off because there was no alternative option. Kind of what the support Alison was talking about there, we were just sending people off into the abyss, where now there is an option. We need to grow these services hugely. There's not enough there, and definitely not enough support in the community. And we could get more people home and look at that the way if we had that home first. But just every time you see a patient, think, do they need to come into the hospital? Is this the safest place for them? Is this where they want to be? Could this be managed at home? And challenge the status quo. Don't be afraid to ask that question. I suppose I'll give you an example of a case that probably you've all come across a case like this in your careers. Well, we had patient Anne who presented to the emergency department, and she had significant cognitive impairment, and she presented with acute back pain, screaming the place down, and she was in agony. She had already got quite an extensive home care package in place. Her home environment was set up. She had her husband living with her, but she was unable to mobilise now. She was very, very agitated. So she came into the ED in the evening. We didn't see her, but she was given painkillers, and amazingly she was doing all sorts of crazy yoga movers the next day not. But she could get up, and we did a functional assessment on her, and she could now mobilise, and she was able to transfer on and off a trolley. And I don't know what your trolleys are like, but on our trolleys in ED, they're very high, and if someone can get on and off them, they're going to be able to manage quite well at home. So she was able to do well. So an ED doctor, as far as they were concerned, medically she was optimised and she could go home on a new prescription of painkillers. So we rang the patient's husband, and he thought we absolutely lost the plot altogether. How could this woman consider go home at all? She was so agitated, so distressed the night before. So we spoke with her husband, and we explained to her that what we'd do is we would bring her out to the house. We'd go out to the house with her and see her in her home environment and stay there with her and see if she was safe to stay at home. If she wasn't, we'd bring her back. But it was just that reassurance for him that this could happen. So it wasn't myself, I didn't do it, it was Paul, my colleague, and he took off he ordered a taxi, and he got a Zimmer frame, he got prescription, he had all sorts of walking devices, toilet seat raises, you name it, off he went in the taxi. Probably needed a van taxi, not just an ordinary taxi for the amount of stuff. Got the lady home. And she did brilliant in her home environment because she was familiar to her. She knew where everything was. She was more relaxed. The husband was amazed at how well she was. But we didn't just leave it at that point, that, because obviously things can change very quickly. We made sure that she was already known to one of our geriatricians, so we made sure that she had a rapid appointment with the geriatrician the following week to make sure the analgesia was working appropriately, wasn't having any longer-term effects on her. And she still managed to stay at home. The geriatrician was delighted with the whole input. So these are cases, and I know traditionally that lady would definitely have come into the hospital, and who knows if she would have got home. She would have been a Patrick. And so by challenging at the front door and just breaking down those hospital boundaries, we're not working in a hospital anymore. We're working where our patients need us to work. I think that's what we have to challenge ourselves around. So obviously it was anyone who knows these two men knows they're under pressure all the time. And so when we started this, we felt under pressure, and we still feel under pressure because we have to. For our team, I know not everyone has this. We got resourced for it, and we felt under pressure to show how is this impacting. So we looked at it from lots of different points. We didn't just kind of go after we also looked at the traditional measures of your patient experience time, but we also looked at the profile of patients coming in. And you can see this is just a retrospective audit we did. I had some students with me, and they pulled charts, and you can see from it that patients who are presenting, these are percentages. 75% had functional impairments, but 7% were nursing home residents. Nearly 40% had an acute or chronic confusion. Again, 75% had an injurious fall or impaired mobility, and then there was 70% on more than 5 medications. So you can see these are all the pillars of frailty, and you can see the age profile. We're seeing patients from 75 up. We've seen people into their hundreds. We looked at what is the profile these patients have at home. So 35% were living alone, 50% had no community supports in place, which makes discharging so challenging. 17 had no informal supports, which is basically they're on their own and they have no one. So that is hugely concerning. And what we also ask is, are you a carer for a vulnerable person? So sometimes what you will find is patients are just desperate to get out because they are the carer for their spouse with Parkinson's or dementia. So, we then immediately contact our social workers to try and put supports in place to support the person at home, not just the patient in front of us on the trolley. This then, I suppose, is looking at the readmissions. So you can see here, looking at 7 days, 7, 30, 60, 90. And I suppose the light blue line is when patients are seen by the fit team versus in the orange line or brown line when they come into ED and are just discharged without any fit intervention. And obviously we're only there 20% of the working week, so the patients do go home. But you can see across all the spectrums there up until 90 days, more patients are staying at home and they're sleeping in their own bed after having a fit intervention than when they don't have the fit intervention. And so Alison put this slide up earlier. This is from when we kind of started, so you can see pre-fit, and it's not just saying, this is a whole system approach. It's not just about putting a team into your ED. It's about challenging the whole system. So looking at your specialist geriatric wards, looking at your day hospital, your outpatient services, your community services. And you can see from that the number of patients dropped significantly, even between Q1 till 5 there in 16, it dropped by 30%. But when you look, and even now, I don't have the figures for today, but when you're looking there between, say, Q1 2015 down to October 2017, that's nearly an 80% reduction in patients listed for long-term care. So these are patients who are getting to go home. And why is it different? Because we're challenging ourselves to look at these patients differently and put more supports in place and get them seen by the right therapist at the right time and by the right doctor and the right nurse at the right time to make sure they are supported at home. So just from a personal reflection point of view, it has been the greatest challenge of my career to date, but it has been, it was reflecting on my own work, and I think everybody, no one goes into work thinking you don't want to do the right thing. But when I look back on what I was doing, I wasn't doing the right thing, and you have to step up and own that yourself. But once you can kind of get to that stage and you look at what you can achieve when you do something differently, it's incredible. Am I done? So that's we'll hand over to Siobhan then.
Hello everybody, my name is Siobhan Julian and I'm the dietitian manager working in Wexford General Hospital. And today I'm going to talk to you about opening the black box of people living with frailty from a dietitian and a dietitian manager's perspective. In Wexford General Hospital we have 4 dietitian posts, with the 4th post coming online in 2018. So you can well imagine our time to explore and develop in terms of change management, the opportunities have been scarce, but we seize them whenever we can. In 2010, there was a watershed for me in dietetics. I went on maternity leave, and when I came back, I noticed that the patient's profile was getting a lot more complex. I wasn't seeing diabetics on the ward anymore, even though they were there. I just didn't have the time to see them. I was seeing people who were starting to lose weight, who were malnourished, and so malnutrition screening came into play around that time. And we all saw Patrick's story, and we meet Patrick every day on many of our wards, I'm sure, because a third of our patients coming into hospital are at risk of malnutrition. A third of our patients going to long-stay units are at risk of malnutrition, and 10% of the people who present to the GP services are at risk of malnutrition. And we've done a lot over the last couple of years in the HSC in relation to malnutrition, screening, assessment and treatment. And that has been something that is being developed and will continue to be developed and associated with things like protected meal times and assistance at meal times within the hospital. But now it's time to look beyond all of that and to see what can we do to help these people who are frail or pre-frail and how we can manage. And data from the Acute Frailty Network has told us that we lose 5 to 10% of muscle strength when you're admitted within the first 24 or within 7 days of hospital admission. And that's a lot of deconditioning, and that can happen and that shouldn't happen. So within the Ireland East Hospital Group, we had what we call the Rapid Improvement Event, and this is what Ireland East Hospital Group are using as part of their change management process. To be honest, I attended many Rapid Improvement Event updates around the hospital, and I go and go, gosh, we're so short-staffed, I won't be able to do anything. And, you know, how am I going to be able to be involved in this? And then I was encouraged to attend. And to be honest, I was cynical going, and now I'm an advocate for it. Here I am telling you my story. And I actually love the whole process. And why do I love it? Because it has the patient at the centre. And I see, even though I'm a dietitian manager, I see patients on a daily basis, and I love seeing patients. But this is giving me a reason to change because it's a multidisciplinary approach, and it's logical. There's reason behind it. At the beginning, you state your reasons for action, your initial state. Where are you now? Obviously, in Wexford General Hospital, we're in a very different place to where Beaumont Hospital is. But that's where we are, and we're going places too. And so we set our target state and identify a gap analysis, and it's based on a solution approach. So ultimately, what happens on the first day, we're all given Post-it pads, and you bring your story, put it on a Post-it pad, the things that you love about your work, the things that you want to improve upon to make Patrick's story better. You put those on a Post-it pad, and they're themed into different strategies, and they're aligned so that you can find the resources to making rapid experiments. What are those rapid experiments? For example, in our group, we went around and we surveyed what is the knowledge of the staff who are working in this hospital. What do they know about frailty? Do they know what it means? Do they know how we can actually work to make it better? In relation to, for example, the rapid experiments would be, for example, I undertook to do something in relation to working with the FIT team, which I'll talk to you in a few moments about. There's a completion plan and a confirmed state, and what's also in there is insight. It's an honest approach. We challenge each other in our learning. And this is what an RIE A3 page looks like. It still looks very busy, but to be honest with you, that's all our aspirations in there and things we can achieve for our patients. So my first RIE, opening the black box, obviously it vitalised me to change. And because it's aligned with the Q Frailty Network principles, you know, it's working towards the standard. It's a multidisciplinary approach. And we've got the CGA was designed by our FIT team. Our FIT team in Wexford consists of a physio and an occupational therapist. So in relation to that, they had the CGA, but they'd nowhere to refer it to in relation to, for example, dietetics. Initially, before the RIE, I said, no, we're not accepting referrals from the FIT team. We don't have a dietitian. We're not going to do that. When I went to the RIE within the first morning, I think I was accepting the referrals from the CGA because I realised I have to change my thinking, you know, moving towards the front door. We're going to be getting the referrals for these patients anyway because we're not screening them, but why not pick them up a little bit earlier and work to get our resources moved around a little bit to make Patrick's story a better story. We also did the in-house baseline survey, and we were involved. I became a frailty facilitator, as did another dietitian in the hospital, and we have trained 3 groups, 2 in the community and 1 within the hospital so far, and that's since November of last year. And it's a commitment to ongoing quality improvement because it's associated with 30, 60 and 90-day rollout. So in relation to, you'll see our branding up there, we've called ourselves the Wexford FIT team, and we're now linking with UCD as well in relation to student training. Student training is something that I always love. I feel as a dietitian you learn so much from the students. And last year we did a student project in relation to diabetes, and this year is Frailty's turn. And what we're going to do is we're linking with UCD. There's a master's program in dietetics, and part of the master's program is that the students do a student project. The student project this year is designed, and it will involve 2 students to assess patients access to food, shopping and cooking ability, cooking skills and social support regarding meal preparation for patients over 60 years who are admitted to Wexford General. This is what Roseanne Kenny would consider as social prescribing. Why? You know, when we get the patients who are referred to us through the CGA, we're finding that 66% are at risk of malnutrition, and you would expect to find that. But there are 33% of those patients that, you know, are pre-frail. So we want to prevent them coming back into hospital. So what do? What we're going to do is, from this project, we're going to see if there's a link between malnutrition risk and the people that are referred to us. But we're also going to develop a directory that's associated with people who can, when they're being discharged. You know, Meals on Wheels is available on this number. You can get online shopping here, or you can, there's a group of people who meet in the local restaurant on a Friday and they get lunch for a £5 or something like that. So that people have a resource to know where to go at home in relation to supporting them around cooking. We are all very much aware, I'm sure any of us that are at home for a night by ourselves, we go, will I be bothered to cook? And for people, that's actually an everyday occurrence. That's actually adding to the malnutrition story. So our student project is a win for UCD, it's a win for all the health and social care professionals, and in relation to our core support and the enhanced professional standards, which is what it's all about. In addition, in November of last year, a document came through, a guideline document for the prescribing of oral nutrition supplements within the HSE. Did you know that supplements cost this country $28 million per year? That's just a standard oral nutrition supplement. So if we can standardise how we use supplements and working towards the food-first model of nutrition, that's again lining up with our student project. In relation to Meals on Wheels, when you go to somebody and say, have you ever considered Meals on Wheels? Sometimes you can be presented with resistance. You know, people don't like that idea. They don't like the word frail. They don't necessarily need to be described as frail. They don't like to think, oh, I need to get Meals on Wheels. But it's something that, like, you may come back on the second or the third visit and they go, you know, you mentioned Meals on Wheels. Can I get the phone number for that? Or if we had our data card with the directory of services, that's something that could be on there to support people. Meals on Wheels is an excellent service, and it's keeping our people out of hospital. So it's to challenge your thinking. Obviously, my thinking has been challenged. It's the multidisciplinary approach. It's powerful and it's inspiring. Everybody from support services to managerial to nursing, medical, and health and social care professionals are involved in the RIE. It's based on a solutions approach. It's not looking for more resources. It's firstly seeing what can you do with your resources, getting rid of the non-value add, putting in the value add, keeping it simple and straightforward. My project is very, very simple in terms of, yes, I'll take referrals from the CGA. We take them earlier. You know, the project relation to students is very simple. We have to celebrate the little things that we do well and to share your success. And never forget what it's all about. It was really interesting when we were doing the Frailty training. Everybody really, really engaged in that. Why? Because we all know somebody who's frail. We're all afraid of the people around us who will become frail. What will we do? How will we cope? You know, it is very, very real for everybody. So we must never forget what it's all about. And as Alison has said earlier, it's the right treatment, the right place, the right time. They're only words I learned last November, but they're now my mantra. That's what it's all about for me as a dietitian. I'd like to thank my colleagues in Wexford General Hospital. I'd like to thank the Wexford team for helping me on the journey. I'd like to thank the management for encouraging me to go to the RIE. And I'd also like to thank my dietitian colleagues who come behind me to support me in this. They're the people that are helping me to see those patients every day. I'd like to thank the Service Improvement Lead within Ireland East Hospital Group. Without them, I wouldn't be on this journey. So thank you.
Thanks a million for all of those thoughts. Great to get the frontline experience as well, which I'm sure a lot of our listeners will feel is really helpful to them. Now, there are some questions online, and I think we might have one or two in the room as well. So just, we have a few minutes now and we'll maximise those questions as much as we can. So first question that we have here is from Nolene Burke, and she's saying the value of rehabilitation and reablement is undeniable. How do we ensure that people with frailty don't miss their chance to get these services because their suitability is assessed during acute hospital admission only? So when things like acute delirium and confusion can influence the decision. So we might ask our clinicians to comment on that.
I think what's really important is we might assess these components at the front door, but we need to make sure we are following these patients. And because what we do is we assess them and then we send the onward referrals onto the ward. So you're not waiting again from for the teams on the ward to decide, oh, now this patient needs rehab, so I want them to go home tomorrow. We're following those patients immediately. So even if they are delirious, we're implementing our delirium pathway and making sure that we are implementing all the components they need. So to make sure that the rehab and the reablement is happening along the journey, not waiting till the end. And so I suppose it's making sure the CGA from the front door has follow-on. It's not just doing an assessment, it's the interventions as well.
And just, Ciara, just out of interest, say I come in and I'm recognised as frail, but unfortunately I can't go home. I am to be admitted up to the house today. So the frail team in Beaumont, just in terms of process, they end at the ED and you then transfer over to an inpatient physio, is it? Or OT, or what way does that work?
It's a bit grey, as usual, and that is, we have obviously specialist geriatric wards and we flag patients who are suitable for those wards. So if they can get to those wards, that's great, because obviously they'll get the geriatric input. If they go to the general medical wards, we obviously have therapists there, but we're currently trialling and seeing, we're doing the PDSA on us going out and following those patients who don't get to the specialist geriatric ward and having that model of the CGA specialist geriatric ward thinking, not necessarily on the specialist geriatric ward, and seeing if we could follow them up and make sure they're getting their rehab wherever they are within the hospital.
Because it would be important, I suppose, to not let those fall.
Exactly, because they can fall through very easily.
A few days can make a big difference in terms of rehab. We have another question here from Liam Coniff, I think you pronounce it, but she's asking, has the FIT team developed a discharge pack for patients for all relevant signposting? So you mentioned signposting for Meals on Wheels and ordering food online, or perhaps for Go for Life, etc. So that's a really good question, actually. So linking those people in from ED out and integrating with community services, has there been any work done on that?
Yeah, there's an awful lot of work has been done on that in the background. So it's developing links with the likes of Alone as well would be another one that we've worked a lot on, to try and develop, but I suppose our theory or ethos is that we're never sending somebody home who needs more than what they came in with. We're making sure that any issues that we do identify, we are following up, whether it's from a dietetics point of view, a speech and language point of view, which I suppose I might assess those patients, but I'm not just working as a physio anymore. I'm thinking about what my patient's needs are. So it's not necessarily a formalized discharge pack, but I know that if I'm sending someone home, I'm making sure they have whatever they need, whether it's a community, a voluntary service, and whether it's a hospital service, we are a day hospital. We're making sure that they're getting whatever they need. It's patient-centered. Whatever they need, we make sure they get.
And just something that's popping into my head in terms of the patient's family. Do you think that this intervention, the frailty intervention, has improved the connectivity between the healthcare professional and the patient's family?
Absolutely, because I think what I have found is that a lot of families don't know what traditionally when they might have been in the hospital a lot of times prior to FIT, they didn't know what the plan was, what was happening. I feel that's part of my job to find out what's going on for the patients, even if it might be nothing to do with physio, it might be whatever medical investigations they're going to have. So it builds that rapport with the family. They start to trust the therapist. So when you're asking, can you take this person home, they are trusting you and what you're asking them to do. I think a lot of time needs to be invested into that relationship, because we need families. We know until the data that 80% of carers in Ireland are unpaid carers. So we need families to help support patients to get home. So we have to ask and build relationships with them.
One other thing that I think would be important to pick up on is, Siobhan, what you were mentioning about the manager's perspective in terms of, oh, how am I going to change? I don't have the resources, I don't have a team. Beaumont has a physio and all of these people, and I've nobody. How can I go about that? That's a significant challenge, I'd say, for a lot of people online. And I don't know if you have any other thoughts around that. Is it just picking something small, starting small, getting some measures, trying to build?
And proving your worth. Somebody once said to me, I met somebody very senior within the HSE, and they said, go over there and tell them that they need more dietitians. And I said, I'm not going to go over and tell them that they need more dietitians. I'm going to tell them that they need more of us, and they need more health and social care professionals. It's not about building an empire, it's about building an empire to do the right, that it works in the right places, and that the service needs more people, everybody in the multidisciplinary team to work together. And sometimes, you can have an area that's very well staffed, and it may need to be that you may need to realign things into doing it in a different way. And then if you do need to develop, it's getting your business case through and putting it through with evidence around what you actually do, and that you are going to have value for money for your patients, that it's going to be worthwhile, as opposed to here's a post and it's going to disappear, and that you're going to show its worth. That's what we've done with the diabetes post. We've shown the number of patients that we are getting through, the impact it is on the type 1 patients that we're seeing within the hospital, and the quality improvement in their hemoglobin A1Cs, and
the data will tell the story.
And it's never giving up. There's a time for everything. We've gone through a recession. We haven't been able to put money into certain posts because that's just the way it is. We did a troika running the country. So now it's putting posts in that show value for money.
There is one other question here online, and I think Alison wants to add to that.
Just add a little bit to Siobhan's point. I think it's worth highlighting that managers have a really important job to do in terms of creating the conditions for success. And often that is creating the conditions for a culture that empowers frontline staff, empowers them to challenge when things are not okay, when we're not doing the right thing. So in a way, creating those conditions involves stepping back a little bit and pushing our frontline staff forward. You can hear, as we're listening today, the power of frontline staff describing their intimate understanding of the issues. It's difficult to argue against it. So I think just to acknowledge, it's a very difficult place for managers of small departments to be as they try to reorientate their staff. But it's a powerful influencing position that they're in too. And remembering one step at a time, starting somewhere really small. Real change happens in real teams. Get your people together and begin somewhere, and keep connecting the system to itself, as Myron's maxims tell us.
We have one question online around, is there a Frailty web page, a central web page, all of its data, tools, resources, etc.?
Great question. Great question, and I guess our work to build a collaborative with the Quality Improvement Division, build a national network, is going to bring all of this together. And we're really excited. We feel we're on the cusp of a wave, really. I think we have highly skilled people who are, as we've heard today, challenging the status quo. They're ready, they're reorientating their staff. Huge ideas about how to make this better, and we've got national QI support. And we've also got national collaboration in many ways, so across the different workforce groups, the programs. We've tremendous ripeness, I suppose, to co-design.
Just conscious of time, we'll hopefully we'll finish off now in a minute, but is it possible to see a one-pager assessment of EDU? So I'm sure you've no problem in sharing that. If you want, Denise, if you want to email me, Roisin.Breen, and we can share that, or actually we could probably embed it in the slide set.
Yes, I can send it to you.
Yeah, so that when it goes up online, it'll be embedded in the slide set, and the same there for Anna Marie. So before we finish off, we'll just hear from Philip.
Great, yeah. Well, what a wonderful session. Very clear rationale, if anyone is in any doubt as to why we need to work differently and need to focus on frailty. Some of the data from Tilda and from some of your own research shows how inadequately we use our health services, and people are driven to use our health services because there's no alternative. So a clarion call to do things differently. And the other thing I really liked, for me, I mean, I liked it all, but was the this emphasis on if every manager said what you said there, I think our health service would be 100 times better than it currently is. And that's where we need to get to, which is where management at all levels, but particularly management or managing frontline teams, realize that their role is to enable them, make sure they're trained, make sure they have a bit of time built into their week so that they can think their way through problems themselves and work out better ways of doing things. Our health service will be transformed. And that's at the core of our QI strategy that we're going to be bringing out to the system shortly. So really thrilled to hear that said by you and not by me. The last thing I'd just like to say is that, I think I've always had very strong links with health and social care professionals, and I've always felt that they're a group who historically haven't had enough voice. I think they're getting more voice now, and you spend a lot of time with patients, you understand things about patients that people who churn through patients maybe more quickly don't, and you are 25% of the solution and maybe more than that. So I think that's really important to take away as well. Thank you very much.
Okay, so without further ado, we're going to sign off, and just to say thank you so much. We had over 70 logins today, which is fantastic, so great to have more talk timers joining us. Just to say that our next QI talk time will be following on from this one, and before that I just have put in a slide there on the National Quality Improvement Team strategic plan and the link for that, and we welcome any of your comments or questions on that. There is a link on the web page where you can feedback, so please do that, and we'd really value that, and pass it on to your colleagues as well. And so our next talk time is the 19th of March at 1 p.m, where we'll be picking up on the conversation we've had on frailty. And I'd just like to again thank so much our speakers today, Alison, Ciara and Siobhan, for your effort and for imparting all of your knowledge with our listeners, and hopefully you'll be able to join in again for the next one to pick up on your learnings from today. Thank you so much, and we'll see you on the 19th.